Welcome to Pedo Teeth Talk, brought to you by the American Academy of Pediatric Dentistry, a podcast show that delivers cutting-edge ideas for the professionals specializing in pediatric dentistry.
Thank you for tuning in to Pedo Teeth Talk by the AAPD. The mission of the AAPD is to advance optimal oral health for all children by delivering outstanding service that meets and exceeds the needs and expectations of our members, partners, and stakeholders. My name is Jessica Lee from the University of North Carolina. Today I'm here joined by Dr. Ron Chu, a board-certified pediatric dentist in Washington. The title of our podcast today is Pulp Fiction: Can We Regenerate a Pulp Following Dental Trauma? So I'm just going to get right into it, Ron. You know, this idea of pulp regeneration has gotten a lot of press in the literature and even in some articles. What do you think about this idea, and can we really regenerate a pulp?
Well, thank you, Jessica. I remember that back in residency, sitting in the lecture hall, listening to Dr. Martin Trobe talking about this whole concept. And at the time, I was so blown away that I thought, maybe I should do an endo residency after pedo. Because this is such an amazing thing that we've always heard that the pulp is something that's sacred. You violate it, it's gone forever. And then to hear that it is actually possible to bring pulp back and to have that tissue to regenerate and to somehow help the root to continue to develop, that was an absolutely mind-blowing experience. And so it seems like it is possible, and I, based on the literature that's been read, there's definitely some success, but it's not very definitive or consistent. And so I think out in private practice, it's definitely not something that's actively pursued, even when the case seemed to indicate for it.
I would absolutely agree with that, Ron. And I think that's also a function of education. You know, how much training do pediatric dentists get in this area of pulp regeneration? And you're right. You know, Dr. Trope brought this idea to the University of North Carolina at Chapel Hill in the mid-90s, where he introduced the concept, of, why is it that when a pulp has trauma and the pulp dies, why is it that we remove the pulp and, we remove it and we replace it? That's the whole specialty of endodontics, right? You remove the pulp and you replace it with something good, and that will last a lifetime or at least 20 years. But, for us in a growing child where the root's only half formed, removing the pulp and replacing it's really not that great of an option because the root's only half formed. So, this whole idea of tissue engineering and regenerative medicine being brought to dentistry was very exciting at the time itself, because when a child that age undergoes dental trauma, we don't have very good options as far as what can we do. I'm wondering, you've been in practice for a while, Ron. Are you able to see this where there might be a need for it, and have you been able to work with your endodontic colleagues or find CE courses that would help you in this area of pulp regeneration?
Not very much. It's surprising how once I got out of academia, how few trauma cases I was able to see. In fact, about 4 years ago, I actually contacted the local hospital and asked, do kids fall and break their teeth? And when they do, what happens? And it sounded like they say that they don't see very many, and they typically just ask the kids to see their own dentist. And I brought up the fact that, there's about 4 or 5 pediatric dentists on your list of house staff. Has no one offered? And up to that point, no one. So I'm now the go-to guy for our local legacy hospital. When they see a child with dental trauma needs and things like that, they now will page me. And so after that relationship was established, I was able to see a few more cases. But because this pulpal regeneration case selection is so specific, I have not seen very many at all. Because for this to work, the tooth has to be immature. The apex has to be open enough for this to happen, and those are very, very few and far in between. Back when I was working for a DSO, we have an endodontist that I worked with. And so when there was trauma, it was easier to coordinate care. But now that I'm out in private practice, it's actually a little bit more difficult to make sure the care happens in a timely manner. So so in short, I have not been able to see this type of cases very much at all, and as of yet have not had to work with anybody to make this happen.
So, Ron, when I work with my endodontic colleagues, they are not comfortable with children. Generally, they just haven't had a lot of experience. That's not a criticism. It's just that they haven't had a lot of experience. So what we've done here is we've actually started doing these regenerative procedures in our clinic and have had success. And so, we go back to the fundamentals of why this pulp should regenerate. So, as you stated, it's a young, immature tooth that's undergone dental trauma, maybe an avulsion, maybe a luxation, but the pulp has been severed in some way. So the assumption is that the pulp is dying or dead. So something has to be done about it. So the pulp has to be treated. And our options are always, get a root canal done with some kind of epixification, or the option number 2 really is this pulp regeneration procedure. And I think the trauma literature would actually call it revascularization instead of regeneration.
Right.
And that's because whether or not are you, the question we talked about earlier is, are you actually regenerating the pulp, or are you actually revascularizing but with something that looks like a pulp, which I think is a big question. Either way, the tooth becomes vital again, and that is the goal, is to have some kind of vital pulp available so the tooth continues to grow.
Correct. Yeah, and I just remember, the length of the root is one concern, and then there's the thickness of the walls. When they are immature with big open apices, the dental cemental walls are also very, very thin. And looking at those teeth, just thinking, boy, if we have to top this off right now, the entire system is just so much more weak and undesirable. And it is absolutely true that our endodontics colleagues, they are probably just as uncomfortable with children as we are with the root canal procedures. Again, just throwing in little... Yeah, another story here is that when I was with the group, I would refer children to my endodontist friend, and they would spend 45 minutes just trying to get the injection done. And I'll come in and help, and in about 5 minutes, I have the injection finished. I have the rubber dam on. I'm getting ready to open and access. And so he looks at me like I'm working magic. And then, but on cases where he's tied up and I'm trying to help him find the pulpal orifices, I could spend 15 minutes and not find anything, and it takes him 3 seconds. So it really just shows that we are truly specialize in our own thing, and on something complex and multidisciplinary, it's best to work together.
I absolutely agree. But, I think, as you mentioned earlier, that, people, the average pediatric dentist in private practice don't have they might have a relationship with the endodontist, but don't have that readily available, and some of the decisions that have to be made. Going back to this regeneration, revascularization, for us, I think the critical point comes when the tooth gets infected. So, yes. If I think of a case and I think a child comes in, an 8-year-old had come in, had a avulsed tooth number 9, been replanted, you watch it for a while because it's a wide open apex, and all of a sudden you see signs of some, an abscess or mobility, or and you think, wow, I've got to treat this pulp. Infection has set in, the pulp is dead, it's been severed, and it's just not healing. So when we go in there, we say, well, we've got to disinfect this tooth because now it's infected. We don't want to take it out because there's going to be this huge defect in a growing child. There have been several things talked about as far as disinfection. That we call that step 1 of the revascularization process. You have to have a sterile environment for revascularization to happen. So how do we create that sterile environment? What do we use and what's available? What would be our options?
So first, I think isolation is key there. We want to make sure that we numb the child really well. We get that rubber dam on, and then as we open into the tooth, be ready to just irrigate, and disinfect. I've read somewhere that the success of revascularization really depends on how well we can disinfect and how successful is the clot, and then how well we can seal everything from the top. So as you say, the disinfection, there's a variety of materials that can be used. Now, the most common that people reach for is sodium hypochlorite, good old household bleach. It's been used as a canal irrigant in the endodontic world forever. There are other things that can be used, though. I've read that hydrogen peroxide can work, chlorhexidine can work, even iodine can work, but of course iodine stains a little bit, so got to be careful there. And then the EDTA and the irrigation. So there is a variety of things, but once the irrigation's done, then it's a matter of putting in a medicine, some disinfectant that will be able to sit there and create that sterile environment. And I've heard that you can do calcium dihydroxide, or more commonly used, it seems, this triple antibiotic paste.
So I think you're correct as far as the irrigation. And, it's sodium hypochlorite seems to be the most common. The one thing we have to be very cautious about is that the idea of pulp regeneration relies on what we think are stem cells at the base of the open pulp. And so we want to make sure that whatever you use is very kind to these stem cells that are alive and are waiting at the base of this open apex tooth. So sodium hypochlorite, if you're going to do it, make sure it's it's diluted. It's maybe 1 to 5% and not the 8% that sometimes people tend to use. To be very gentle and make sure you have a syringe that has the opening on the side and not on the apex, so you're not shooting through the open apex at all. So the technique itself, it has to be very thoughtful, keeping in mind that you have these stem cells, and I think they've isolated 3 or 4 down at the base of the open apex tooth that are going to regenerate this pulp. But all the things you mentioned absolutely can be used to irrigate the area. And then, of course, you want to put a medicine down in it to make sure that you create a sterile environment.
So from the literature, it seems that the concentration of 2.5% seem to be best compromise between efficiency and toxicity. And the other thing that's, again, without using a lot of this, people don't realize is that when the 2.5% bleach rises to the temperature of body temperature, it actually behaves closer to 5%. So as we warm these solutions in body temperature, they actually gain further potency. So you're absolutely right. To keep it gentle is key.
And going back to the medicaments, is you've mentioned the triple antibiotic paste, which I hear now they're actually thinking about a double, taking out the minocycline, which stains teeth. And then, of course, the good old calcium hydroxide that people use. It's interesting because 10 years ago, they thought that calcium hydroxide actually may have been too harsh and may have damaged the stem cells at the base of the tooth. But I think it's coming back around saying that you can use the calcium hydroxide. Whatever medicament you use down there, to make sure you seal it and give it time for the tooth to disinfect before you actually induce some kind of bleeding. And that is, step 2, as we alluded to. So, you've gone, step 1 is this disinfection phase, bring them back in about 4 weeks. Step 2, and you mentioned, Ron, about bleeding and the clot. Can you tell me a little bit more about that in the stage, in the second visit?
So in the second visit, and once we have some assurance that everything is sterile and everything, we go back in there. Again, it's a little different than the typical dentistry that we do. We do need a sterile environment to ensure success. So we're careful with what instruments goes down the canal and what's touching. But yeah, we got to have everything sterile, and we generate this bleeding and allows it to slowly fill the canal up to about the level of CEJ. And then we seal it off to allow this clot to become the scaffolding for the cells to migrate in. This goes into this microcellular tissue regeneration level, and it's a little bit beyond my scientific background here, but the cells would then travel through these established structures and begin to form begin to differentiate and form what they need to form in order to become a vital system again.
Absolutely, Ron. I think the scaffold, or the induction of bleeding from the base of the pulp to fill the chamber, that scaffold that we've generated by doing that is critical. Because if you don't have this blood clot that forms inside the canal, you really don't have anywhere for these cells to go, for the stem cells from the base to be able to fill the chamber. And so that induction, that bleeding induction that we've created brings those really nice, healthy cells up into the chamber and helps recreate or regenerate a pulp or pulp-like substance. It's interesting because I was reading some studies about using different kinds of scaffolds. If you can't get the chamber to fill with blood, do you use your own systemic blood, of a patient? Do you draw blood from their arm and try to put some in there, or do you use kind of a synthetic scaffold? It all seems to me that the best scaffold is the pulp blood that you can fill back up in the chamber, and this clot that you are able to create. And I think that seems to be the best mix as far as being able to bring up those stem cells into the pulp chamber and regenerate this pulp. You mentioned the seal. Let's talk about, what you've induced bleeding and now you've filled the chamber. What do you use as the seal on top of this blood clot that you have generated in this tooth?
Well, so in the past, glass ionomer has been used, or even composite's been used. But I believe for the material and technology that we have right now, MTA is the thing that's been mentioned the most. So once we reach the desired level, the MTA can be mixed and placed right on top, and then cover it with glass ionomer composite to allow it that time to set. And when it sets, it seems like the seal is quite superior to anything else we have before MTA came to be.
I would absolutely agree with you on that. Before we had MTA, we tried all sorts of things to seal off this pulp, but MTA has been unbelievable for this procedure itself. But there are some drawbacks to MTA, and that is that it stains. Mm-hmm. And I don't know if you've seen that in your hands, that you have to be very careful. We've gotten to the point where we actually put bonding agent in the corona portion. So when we add the MTA, the dentinal tubules are sealed a little bit, so the MTA does not stain as much. Yeah, so that was kind of a technique we use. And it's interesting you say, well, we could seal it with MTA, glass ionomer, or composite. We use all three. It's MTA
Yes.
first, glass ionomer second, and then the composite on top. It's just give you extra, sealant on it so that nothing leaks in to this beautiful, nice pulp.
Yeah, tooth is a 3-layer structure. We might as well repair it in a 3-layer way.
Exactly.
Now, has the white MTA been tried? I mean, I've heard that the white MTA seem to work okay, but over time it stains anyway.
A little bit, probably not as bad, but we're still seeing just a little bit, and it's okay. We still use it. We still use MTA for this procedure on an anterior tooth, and what we've done now is we've gone to bleaching. After we feel like this tooth is, a year out, and we see it continue to grow, and there's a pulp-like substance in the tooth that's, roots are getting longer, dentinal walls are getting thicker, and we feel pretty good about this tooth. We've gone back in and just opened it up and put a little pellet of sodium perborate over a few days, and it's amazing how it bleaches the tooth back out, and that it's able to get that color back to where it needs to be. So we've had pretty good luck with just a little bit of bleach behind the tooth and getting that discoloration out. So, when we talk to parents about this procedure, we say our goal is to save the tooth, and then I promise we'll make it pretty. So
Right.
we want to save the tooth first. We want to regenerate this pulp, revascularize this pulp, and then I promise that we will be able to make it pretty. But right now, if we don't do this, she may lose the tooth. You mentioned fractures. For an immature tooth, those teeth will fracture right at the CEJ.
Well, and it seems like the kids who sustain trauma always tend to sustain them again and again and again. So,
absolutely, absolutely. So for us, this is worth a try. And so, we kind of made the title here, Pulp Fiction. Does it work? I think the long-term data now on pulp regeneration, or I would call it revascularization, because I'm not sure we're actually regenerating the real pulp, but something close enough to it, has actually gotten pretty good. Some of the case series of, I see anywhere from 70 to 100%, where the tooth is in the mouth for 1, 2, 3, 5 years.
Great.
Which is amazing. And Ron, it's really, if you keep a tooth on a 10-year-old for 5 years, that's pretty good.
It makes a huge difference. It makes a huge difference, yeah.
Absolutely, because, in a growing child, if they lose at 15 versus 10, it makes a huge difference, after they've done a little bit of growing, and, so the defect doesn't get any greater. So for most of us is that, let's keep this tooth in as long as possible in a growing child. And, to me, that's a success. That's a success in my book.
Right. And as the success rate goes up to 70, 80, close to 90, the competing protocols will probably begin to converge, and it'll become something that we might be able to more formally teach and have people do the same way. Now, there is a chance that it doesn't work. But even if it doesn't work, if we have bought those years during the growth and development phases, we would have been able to preserve the bone, and that will make a huge difference aesthetically long term.
Absolutely, I think in a growing child, preserving that bone makes all the difference. And I love your point, and we'll close with that. Is that there's so many different protocols out there that having them all converge on a set protocol that could be taught and disseminated more widely beyond the walls of, University of North Carolina or University of Washington, or to be able to have this more adopted by practitioners. I think that's a good way to go. And have pediatric dentists more comfortable with it. And I think the endodontists may be more comfortable with it, but yet they're not as comfortable around kids. We're comfortable around kids. Maybe we can get more comfortable around this procedure, and I think we would really do a service for this population.
I do believe it, and then I think as the protocols firm up and the reporting channels gets established, I think we'll be able to really see what makes this work better and what doesn't, and in the long term be able to save a whole lot more of these teeth.
Great. Well, this has been very interesting. So thank you, Ron, for being on Pedo Teeth Talk with me, Jessica Lee, today. And finally, a big thank you to you, our listener, for tuning into our show.
Thank you very much.
Pedo Teeth Talk is brought to you by the American Academy of Pediatric Dentistry, the show that delivers cutting-edge ideas for the professional specializing in pediatric dentistry. If you have any questions or comments, please email info@aapd.org. We welcome your ideas for future shows and guests. For more information on the American Academy of Pediatric Dentistry, visit aapd.org.